Good evening. I would like to thank the organizer of this meeting, Said NGO, and Merck for inviting me to be a speaker about colorectal cancer tonight. So I will go through the colorectal cancer, the incidence, diagnosis, prognosis, and staging, together to understand the treatment goal at each stage, and also what are the factors that guide the treatment decision in this disease. Then Dr. Hadi Ghanem will talk about the treatment approaches in metastatic colorectal cancer. So if we look to colorectal cancer, it is the third most commonly diagnosed malignancy all over the world and the second leading cause of cancer-related deaths globally. The burden of colon cancer is going to increase, and it will be over 60% by 2040. And if we look to the incidence, it will be around 1.1 million new cases all over, and with 600,000 deaths per year. Geographically, the colorectal cancer is a high in incidence among the very high human developmental index. What about the cancer itself? And in the colorectal cancer, it's the same. The cancer is an uncontrolled cell growth. And in the colon, rectum, or appendix, this is what makes the colorectal cancer. If we look to the etiology, it is around 5 to 10% of cases inherited, and it is related to genetic risk factors. And among these inherited cases, we know the hereditary non-polyposis colorectal cancer and the familial adenomatous polyposis. Among the colorectal cancer, we know that 90 to 95% are sporadic, which means they are not related to genetic mutations or genetic predisposition. And among these, we have the non-dietary risk factors that predispose us to have colon cancer, like smoking, tobacco, inflammatory bowel disease, and previous malignancy, together with metabolic syndrome like obesity and chronic non-steroidal anti-inflammatory drug use. Dietary factors, these are factors that we can work on, like red meat, processed meat, alcohol, and possibly high iron diet, cheese, or animal fats. What about the hereditary forms of colorectal cancer? We know that Lynch syndrome, most common form of hereditary cancer, and it is about 3 to 5% of all colorectal cancer malignancies, and they are triggered by a mutation in the gene MLH1 or MSH2. And these mutations predispose these patients to have more than colorectal cancer. They can predispose to have other sites of cancer like stomach, brain, and breast. The familial adenomatous polyposis accounts for less than 1% in colorectal malignancies, and they are triggered also by a mutation in the tumor suppressor gene, the APC gene. And in these patients, more than 100 polyps can be present in the colon or the rectum, and also they will start at earlier age, like in adolescence. This is what makes the importance of knowing that these hereditary forms of colorectal cancer, they exist, and try to detect in the family the presence or not of these diseases. What are the symptoms of colorectal cancer? We know that symptoms related to colorectal cancer can be non-specific, like abdominal cramps, abdominal pain, weakness, fatigue, and also we should always keep in mind colorectal cancer in any change in bowel habits, right? Like, for example, constipation alternating with diarrhea, rectal bleeding. Sometimes blood in stools can trigger or push the patient to ask for a GI consultation and then for other tests to detect colorectal cancer. But we should always keep in mind that these diseases can be asymptomatic. So we should go further to detect colorectal cancer at early stages by asking for doing the colonoscopy after 45 years of age, and then follow patients with hereditary diseases. So to diagnose colorectal cancer, we should go for colonoscopy for colon cancer, and also we can go for CT-guided CT scan, so to make sure that it is associated with colonoscopy, and also CT scan for lung, abdomen, and pelvis if we have cancer, to see if it is metastasized, and also MRI of the abdomen to see if the disease is operable or not. We can go also for laboratory workup. Sometimes we can detect anemia in a man or in a menopaused woman, and in this case we should go further for investigating the colon to see why the iron deficiency anemia is present at this age group. CAA is a tumor marker for to detect, it's not used to detect colon cancer, but we can do it before surgery or after, during follow-up, and its rise in CAA can be an indicator of relapsing or metastatic disease. What about rectal cancer? Rectal cancer, a digital rectal exam can be a tool to diagnose a mass in the rectum, and also we can do we can do colonoscopy or rectosigmoidoscopy to detect the disease itself. This is how a polyp can develop into invasive carcinoma. We know that a hyperproliferation inside the mucosa can lead to malignant disease or invasive disease. So it needs like 10 years to develop from hyperproliferation, adenomatous polyp, small, large, severe dysplasia, then it goes to adenocarcinoma, and then it goes to invasive carcinoma, and at this stages this is a malignant tumor. So we know that it needs a lot of time for this tumor to develop, and this is what makes the colonoscopy very useful tool to detect the colon cancer at early stages. Together, we need to know if our tumor has metastasized. If we have definitely a tumor, we can go for radiological imaging like CT, MRI, ultrasonography, and also PET scan can detect if we have a metastatic disease, and the diagnosis is confirmed when we have a biopsy with histocytological confirmation of the tumor itself. How can we stage colorectal cancer? We know we use the TNM staging system. The T is for the size of the tumor, the extent of the tumor growth inside the mucosa through the muscularis propria, perirectal tissues, visceral peritoneum, adjacent organ structures. This is what makes the tumor the T from TIS when the carcinoma in situ is there to the T4B. The N is when we have the nodal invasion. So here I put this slide to show you the depth of invasion of the tumor through the mucosa, then the submucosa through the muscular layer, the serosa and the subserosa that makes the tumor becoming T4 or T4B. The nodes is when we have nodal invasion. 1 to 3 regional lymph node is the N1. More than 4 regional lymph node is the N2. And we divide N2 into N2A and B to see if we have the tumor invasion is more than 7 or regional lymph nodes. So what makes our staging is adding the T to the N and then to the M. If we have metastasis, it is MA, M1, and if we don't have metastasis, it is M0. Why it is important to stage our colorectal cancer? Because the survival is different. If we look to the survival at 5 years, we can see that localized disease, they have 90% 5-year survival compared to 14% only if they are metastatic. And for regional disease, we have 72% of patients are alive at 5 years, after 5 years. So it is very important to detect colorectal cancer at early stages. What is the prognosis of patients with colorectal cancer? We know that patients with colorectal cancer, even if they are resected, even if they are at early stages when the disease arrives, 30 to 50% of the patient will relapse during the coming years. So it's very important to detect this disease and to treat it at early stages. Long-term health impact, if a patient have a colon cancer and he underwent surgical resection, he can develop a lot of side effects, definitely. And patients who survive a rectal cancer, they were treated with pelvic irradiation, with chemotherapy. Those patients may develop stool frequency, incontinence, radiation proctitis, perianal irritation, and also together bladder dysfunction, sexual dysfunction, and sometimes we need to do colostomy, and this may affect the body image. So it's very important to keep in mind patients when they survive colorectal cancer, 50% of them may have chronic diarrhea, and this will affect their quality of life. What are our treatment goals? We know that when we treat patients with colorectal cancer, our decision should be individualized to our patients. And the physician should take into consideration the prognosis, the toxicity of the treatment, and also the patient choice. And we should always keep in mind if we need to keep to extend the survival of the patient, to shrink the tumor and decrease the tumor to make it resectable. Are we aiming to cure the patient? Are we aiming to control the disease itself? So all these factors will determine our decision, and it should be tailored to our patient. When we think to shrink the tumor, sometimes a patient will arrive, the tumor is very big, and the surgery will be mutilating for the patient. So we ask, they come to us and we give chemotherapy or treatment neoadjuvant before going to surgery. And by thinking of shrinking the tumor, this is very well evidence-based that this will prolong the survival, this will give quality of life benefit, it controls the symptoms, and also the surgery will be feasible and give better results. So if we look to the treatment strategies, we have 3 strategies that can be present. For example, patients can be resectable, so these patients should go directly to surgery, and according to the pathology and the staging, we should go to adjuvant therapy, or the patient will be satisfied only by doing the surgery. If the patient is potentially convertible and the surgery will be done, but we need to decrease the size of the tumor, the patient will go for neoadjuvant chemotherapy, try to shrink the tumor, then we send the patient for surgery, and followed by treatment adjuvant chemotherapy. And the patients could come with unresectable disease, Unconvertible with metastatic disease, this patient may go to only systemic treatment according to the site of the tumor, which was the chemotherapy or the target therapy. The colorectal cancer, as we said, 20 to 30% of the patients come to us with metastasis. And if we look to patients who come to us at earlier stages, 30 to 50% of them may develop metastasis during the coming years. So the sites the colorectal cancer metastasize to are first the liver, it is the most frequent site, followed by the peritoneum, and followed by the lung, bone, and the brain. So we have many sites, and we should, when we follow the patients after doing surgery, chemotherapy, we should follow and search for these sites of metastasis. So several factors influence our decision in treating patients with colorectal cancer, and we should take into consideration, as we said, the patient-specific factors, the age, the organ functions, the performance status, and the comorbidities. We should take also the socioeconomic factors of the patient, the quality of life, the convenience, and the tolerability of the drug that we use in giving as adjuvant or neoadjuvant or in metastatic setting. And also we have a lot of disease-specific factors. Actually, we look to a lot of biomarkers, and the tumor location, is it on the right, is it on the left side, and also the mutation and the biomarkers, we're going to see it in the coming few slides. The main biomarker in metastatic colorectal cancer that can determine our choice of treatment is are involved in the EGFR signaling pathway. And among them, we know the RAS, the BRAF, and the PIK3, CA, and PTEN. All these biomarkers are in the signaling pathway of the EGFR. And some of them are predictor of poor outcome, so they are prognostic, and some of them are predictive of the response to treatment or the resistance to treatment. If we look here, we have the RAS mutation. If we have a RAS mutation, this is a predictive that the patient will not respond to anti-EGFR. If we have RAS wild type, we can choose the EGFR, the anti-EGFR, as a treatment in these patients. If the patient have BRAF mutation, it is a predictive of resistance to anti-EGFR treatment. So it is very important to determine these biomarkers, try to find these genes, if they are mutated or not, if they are wild type or not, and to determine what kind of treatment we can offer to our patients. So the guidelines, the ECN and NCCN guidelines, the ESMO guidelines, are the guidelines who recommend or who can give our, they can guide us among the most recommended molecular biomarkers we have and we should do. So the most recommended for routine assessment are the RAS, the BRAF, and the MSI, which determine the ability to respond to immunotherapy or not. The RAS and the BRAF for the EGFR, anti-EGFR treatment, and the BRAF to determine if our patient can respond or is resistant to anti-EGFR. The HER2 is recommended for selected patient, and it is also an option. And what is very recommended is to do these at least first 3 biomarkers, RAS, BRAF, and MSI. The anatomy and of the large intestine, we know that the large intestine is divided into 3 parts. The ascending colon that reach the hepatic flexure, the transverse colon, then the splenic flexure, descending colon, and the sigmoid and rectum are the descending colon. And we know that the function of the colon is to absorb water, vitamins, and nutrients, to compact the feces and move it to the rectum, and to secrete potassium and chloride. Actually, we divide rectal cancer into two big parts, those that occurs in the right colon and those that occurs in the left colon and the rectum. 2/3 of colorectal cancer occur in the left colon and the rectum, and 1/3 of colon cancer occur in the right colon. And we know actually that the tumor that occur in the left colon have better prognosis compared to those occur on the right colon. So the right colon have worse prognosis compared to the left colon. So actually, tumor-sidedness is a surrogate for molecular biology in metastatic colorectal cancer. The right side colon cancer is characterized by high TNM stage, microsatellite instability, BRAF mutation, and a lot of molecular specific characteristics that determine the resistance and the metastatic behavior of the right side colon cancer. While the left colon cancer is characterized by the EGFR positive wild type and HER1, HER2 amplification with chromosomal instability. So, and we also, again, I insist on having better prognosis for the left colon compared to the right colon. So if we want to wrap up, we can say that the colorectal cancer is the third most commonly diagnosed malignancy and the second leading cause of cancer-related death. Symptoms include change in bowel habits, rectal bleeding, blood in stools, abdominal pain and cramps, weakness and fatigue, and sometimes unintended weight loss. Treatment decision in metastatic colorectal cancer should be based on discussion between the patient and the physician and should consider disease characteristics, prognosis, efficacy, potential toxicity, and patient choice. There are three main strategies for treating colorectal cancer. They are mainly centered around resectability and the primary tumor and the metastasis. So either we go for surgery followed by treatment, or we give chemotherapy, then decrease the size of the tumor to facilitate resection, or if the tumor is unresectable or unconvertible, we can offer only chemotherapy. Disease-specific biomarkers shape our disease decision in metastatic colorectal cancer. We should always think of doing the biomarker testing because they can be either prognostic or predictive, or they can be both. So we should always think of doing the RAS, BRAF, and MSI status for all our patients. I thank you for your attendance.